Hi guys, Dr. Gillard here. This is our week 1 CVPP lab, kind of the lecture I give before. And here we go. So pulses of the upper extremity face and some orthopedic tests. All right, I built this program using Bates and Segal. These are the only 2 books recognized by the Board of Chiropractic Examiners. So if you get board questions when you go to the boards, these are the books that you will use. Jarvis is not a board book, so I don't use it. Okay, palpating the pulse. All right, so we're going to be taking pulses. What in the world? Oh, sorry about that. I'm not sure how this slide got here, but I guess it's just like a general. Okay, we're going to be taking pulses. I guess that's what that is. So when you take a pulse, what are you feeling for? The rate, rhythm, and the amplitude, of course. 3 stars, so probably could be a question on the exam. Or depending if we're doing them by quizzes online or in person, I'll be asking you. And we can talk about that when we get closer to the midterm. So what are you palpating the pulse for? Make sure you know the rate. You can get a heart rate that way. The rhythm should be a steady rhythm, right? Pulsus paradoxus we'll talk about as we go through the program. Anybody know what that is? Patient takes a breath and the pulse disappears. As the patient breathes out, the pulse comes back. That's pretty weird, isn't it? We'll explain that when the time comes. Palpitations, maybe the rhythm is not, it should be pulse, 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 pulse. Maybe it's a crazy rhythm. Pulse, 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 pulse. So palpitations, we'll talk about those. Supraventricular tachycardias. The amplitude, it should be a nice steady pulse. It shouldn't be like you can barely feel it, or it shouldn't be pounding like he just ran a 100-yard dash, but he hasn't, right? So we can rate the pulses using a +2 scale as normal. Bounding pulse, you should know the name of that. All the books, Bates calls it a bounding. You should know it as a bounding pulse. Again, Jarvis is in a board book. Bounding pulse. A normal pulse or a weak pulse, or maybe you can't even feel the pulse. So we need to know what conditions can cause this. So what can cause a bounding pulse? That's a great question, isn't it? So what I'm interested, wet berry, we're not going to run into that in this country. Fear and anxiety, probably, unless they're really fearful anxiety. The answers I want you to know are anemia. Anemia decreases the viscosity of the blood, therefore it increases cardiac output, and you get a really strong pulsation to make up for that decreased viscosity. Hyperthyroidism drives the heart really fast as well. Aortic sufficiency is notorious for causing a bounding pulse. So when systole occurs, blood is injected into the ascending aorta. Diastole occurs, the blood goes back and it closes the semilunar valves. But if the semilunar valves are leaky, the blood gushes back into the left ventricle here. So what? Well, now during diastole, remember blood is going to fill this ventricle up again, and then we have a little mini systole here with the atria, which tops off the blood. Bottom line, too much blood. We're going to have an overfilled ventricle every single time, and it's going to eject too strongly. Remember, if the ventricle is overfilled, it ejects super strongly. And therefore you'll get a bounding pulse with aortic insufficiency. Okay, other fun facts. If a pulse is decreased on the right, let's say a radial pulse is decreased on the right, but not on the left, and they're having pain, maybe it's an embolism. There's a beaver dam or something clogging up the pipe. Maybe they have thoracic outlet syndrome. An S3 heart sound, which we'll talk about when the time comes, a ventricular gallop. Sounds like Tennessee, Tennessee, short, short, long, short, short, long, short, short, long. That can also produce a pulse that is bounding. What about the opposite, a weak or thready pulse? So maybe really hard to palpate. So there are some things that cause a weak pulse. The easiest one is anything that decreases cardiac output. The pump isn't working very good, so that could do it. Things like heart failure. Another thing, maybe the heart is working okay, but the aortic valve, instead of being leaky, it's too strong, it's too stiff, and so you can't get a good ejection from it. That will decrease the cardiac output, right? If there's a beaver dam at the aortic valve. Same with the mitral valve. Okay, coarctation, we'll talk about that when the time comes. Peripheral artery disease can cause it. We'll talk about that when the time comes. So, I mean, you guys know how to take a pulse, right? I really don't have to tell you too much, but I can tell you the board books show a little bit different way to take it. You should always use 2 finger pads if you put your fingers on your radial pulse there, right at the wrist. And you should use 2 fingers there. 3, I guess, if you have tiny fingers, but 2 is usually fine. Here's a trick. So let's all take our pulse now. So I'm just pushing on my pulse. I can feel it, but let's pretend you can't feel it. Even if you can feel it, I want you to try this trick. So everybody's got the radial pulse, right? 2 fingers on the radial pulse. And I want you to push straight down really hard. And now slowly back off the pressure. And I just felt a huge squirt of blood. That's a good trick for finding pulse. If you compress the artery completely, let the blood flow back up, and then release the pressure, it comes flying out. And that's a good way if you're having trouble finding a pulse to do it. Okay, this one I don't think you know, the superficial temporal artery. So you know it, right, from lab. It's right by the tragus. Here's the tragus of the ear. So all you do is slip those 2 fingers out and put the pads right here and here. Let's take a minute and see if everybody can find it. So I got my fingers right here. I'm pushing in really hard and releasing and see if I can feel it squirting. Some of you might actually have to search around up here. There's a temporal and a parietal division of the superficial temporal. You might have to go up here to see if you can find it. But this may be one task you get. You might be asked to palpate the superficial temporal artery. How do you do that? Go right in front of the tragus of the ear, put 2 fingers down there, and there you go. Now we need to talk about giant cell arteritis, aka giant cell temporal arteritis, because it so commonly affects superficial temporal artery. So this is the most common systemic vasculitis that there is. This can lead to blindness. I've had 2 patients over my 30-year career who had this. So it is out there. It is a severe inflammation. They're not 100% sure. They think it's an autoimmune attack. It absolutely loves the superficial temporal artery. And if it's in the superficial temporal artery, it's probably in the ophthalmic artery as well. And that's the danger of this thing. Because if your ophthalmic artery gets swollen up with inflammation, it's going to cut off the blood flow like a beaver dam, and there goes your retina, and you can become blind with this thing. Favorite targets: temporal artery, ophthalmic artery. It likes the vertebral artery as well. Really tough to diagnose. Symptoms are TMJ. They think it's a TMJ problem, but it's not. They're touching what they're feeling is a sore superficial temporal artery. So headache. Guys are over 50. Guys, especially smokers, tend to get this over 50 years of age. The exact cause is not known, but it's caused by old age. You have a risk factor for developing it. Again, thought to be an autoimmune attack against the endothelium of the superficial temporal artery. There's something about it. Diagnosis is made. They took a branch of the temporal division here of the superficial temporal, and they put it under the microscope, and they look for an inflammation of that, and that makes the diagnosis. In the meantime, they put them on steroids, corticosteroids, because until proven otherwise, you have to assume the ophthalmic artery is swollen up as well. Okay, the erythrocyte sedimentation rate is also elevated in these patients. They have slight anemia. So here's a new word for you. You got to know this word. It's pronounced Amaurosis fugax. Amaurosis fugax. So that is a sign that the patient could have superficial temporal arteritis. What is it? The patient will say, it felt like a shade. Somebody pulled one of those old-fashioned shades down over their eyes, and they went blind. It's a slow process, like one of those old pull-down shades. And what does it indicate? It's highly associated with giant cell temporal arteritis. And you have to assume at that point that the ophthalmic artery is all swollen up with inflammation, and they're in trouble of losing that eye. Okay, that's what Amaurosis fugax is. Sometimes they're palpable chords. You can palpate this and feel these chords. And sometimes you can't. So palpation, I mean, you just squish it, right? Just as we said, you put your 2 fingers in front of your tragus, push down, and poke around for it. If you can't feel, push down really hard to cut off the flow there and back the pressure off to see if you can find it by squirting. Brachial artery, okay, my pet peeve on this one. So brachial artery, of course, runs in between the biceps and the triceps furrow. Okay, and that's where some of you have been taught to I think all of you have been taught to palpate. That is not where you palpate the brachial artery, according to the board books. Even Jarvis, I won't get into the story of where this technique came from, but I would not use this on boards, and certainly don't use it for me, because I won't be happy with this. For me, you want to be in the cubital crease. What's the cubital crease? That's the crack of your elbow. Here's the cubital crease. Do I have my drawing tools on? Let me see if I put them on. I did put them on. Cubital crease. Here's the medial condyle. Going just like that. That's the crack of your elbow. That's the cubital crease. See the biceps tendon here? Right? The biceps tendon. The brachial artery is right medial. There it is, right medial to the biceps tendon. So if you straighten out your elbow and bring up your condyle, your medial condyle, you can trap this artery really easily against that condyle. It's super easy to palpate that way. If you try to push under here, there's nothing to trap it. Unless the guy's got big biceps, then you can sometimes pinch it against the biceps. But normal humans, it's really hard to find there. So in CCP, I guess you don't have it. But next quarter, they know I teach right out of the board book, so it is legal to do that there. So this is where it is. So there's the crack of my elbow. You can see the crease line there. And that's where you look for it. When I took this picture, it was pounding away right there. So that's where you feel this. Okay? I'll ask, where do you palpate the brachial artery? In the cubital crease. I'll say, what's the cubital crease? You'll say the crack of the elbow. Okay? It's difficult to find up in this region, if not impossible. Usually I have you guys all do this now. Straighten your elbow out. Let's do it right now. So find the crack of your elbow. Okay? Make a bicep. Find your bicep tendon, but stay in the crack of your elbow. Stay right here. And now put those 2 fingers, just like I have here, slide those off medially. Now straighten your elbow out. And you should feel it pounding right there. If you don't, go further medial. Mine's just pounding like crazy there. If you still can't feel it, push down really hard, wait for a couple seconds, and then slowly release the pressure, and you should feel it squirting. Usually about this point, somebody in class, the light bulbs will come on. Oh my God, I feel it. I finally feel it. Well, that's the way you should do it. That's also where you should put the bell or the diaphragm when you're taking blood pressure. We'll talk about blood pressure when the time comes. All right? Okay, done ranting about that. Radial artery, we're pretty good, but I'll show you how the board books want you to do this. Of course, it's medial to the styloid process. That's right at the base of your thumb. You guys all know where that is. I don't have to belabor this point. This is from Bates. Ancetal, this is the way you're supposed to take the pulse. You're not supposed to wrap your fingers around like that. That's from Jarvis, right? I wouldn't do that if I was being tested with the boards, because that's not a board book. So Why they don't go by the board books, you can ask them. I don't know. Don't know what to tell you on that. But that's the way I want you to do it, just like the board books say. Take the radial pulse, just put the wrist like that, take the pulse. Pretty simple as that. I don't think I need to say anything more. You can read about it more if you want. Ulnar artery is a little more difficult. Again, you're going to do this little rabbit ears thing. And this is Bates again. That's the oldest board book. Search around for it. This one's a little harder to find. All right, special testing. Now, I might try to get a video out here. I'm trying to get my wife to volunteer, and she's hesitating. But let's see if we can work our way through this. I might be able to upload a video of this later. But it's pretty self-explanatory. So modified Allen's, all three books, even Jarvis talks about the modified Allen's test. Modified Allen's test is a test for the patency of the ulnar artery. What does that mean? It means that it's a test to see if the ulnar artery is functioning, specifically if the ulnar artery is contributing to the palmar arch of the hand. It contributes to the superficial and deep palmar arch of the hand. The hand has double circulation, right? All of these muscles are fed by the superficial and deep palmar arch. A certain percentage of people, they have maybe a double here, or maybe their ulnar artery goes like the ulnar nerve and it just goes into the little in the ring finger. They don't have double circulation. Well, who cares about that? If you're having an angioplasty of your heart, you're going to definitely care about that, because they're going to stick a catheter up your radial artery, and they're going to wind that thing all the way into your heart, all the way into your coronary arteries, and to kind of get the gunk out of there if you're having chest pain. It's a pre-heart attack, right? That's where they go. Why do they go that way? Because the rate of blood clot from this procedure is only, I think it's about 6%, the rate of blood clot. If they go in through your femoral vein, the rate goes up to about 15 to 20%. And those are big clots, and they can do some damage. They get stuck down in your lower extremities. So this is a very popular place to put a catheter. And then, anybody see a problem? Well, what if they don't have a patent ulnar artery? What if the ulnar artery is not contributing to the arch here? And they stick a catheter up here. Well, you're going to lose your hand during the procedure. And that's what's happened before they started doing this modified Allen's test. So the modified Allen's test will be done if you ever have some type of catheter procedure here in your radial artery. Okay, so let's check it out. Everything I just said you can read about. Everything I just said you can read about. There's a catheter going in. All right, let me just walk you through it by the pictures. There's the sensitivity. Specificity is really good on this test. I mean, if this is positive, if you do this test and your hand stays grossly white looking, you better not let anybody stick a catheter in your radial artery, because you'll end up killing part of your hand. Sensitivity is not the greatest, so if your test is negative, you still have a little bit of risk of having some hand damage during this procedure, but not too bad. All right, so step one. So everybody do this. And you don't have to hold your hand up in the air. You can just hold it out in front. So step one, this is the patient. You're going to open and close your fist many times, and then squeeze it really hard and hold it there. What you've done is just pump the blood out of your hand, right? No more blood can get in there, and that's what you want. Don't have your patient, this is your patient, don't have them open the hand yet. Okay, while their fist is still closed, you are going to come down with the pads of your thumbs, not the points, not the tips of the thumbs, but the thick pads, right in the crack there of the wrist. And you're going to push down pretty hard to the point you compress the blood flow. So you're going to keep the blood out of there. Once you have it compressed, you're going to have the patient open up their fingers, and it's going to be all gross and white looking. Why? Because there's no blood in there. Okay, awesome. That's what you want. And let's see. And then what you're going to do is open the ulnar artery. right? This is what we're testing to see if blood's going to return to the hand. If the patient has a normal palmar arch, deep and superficial, their hand will stop looking so grossly white and it'll turn red within 5 seconds. And that's a normal response. If they have a weird ulnar artery that only goes to the little finger, these might come back to color, but this will stay all ghostly, kind of grossly greenish white over here, bluish white from lack of blood flow. So that's a positive test, and they should not get any catheter stuck up there. Everybody good with that? It's pretty straightforward. Okay, you can read through it, 5 seconds. Yep, so this patient's normal. His hand is turning back colors within 5 seconds. So that's it. It's simple as that. What's a positive? It's a failure of the skin to blush or turn rosy red within 5 seconds. And it indicates faulty collateral circulation. Something screwed up with the ulnar artery. Okay, everybody good with that? It's contraindicated for any type of cannula, catheter procedure of the radial artery. Everybody good? Okay. Let's see. Yep, everything I said already. Now there's another test. This is the old one. It's been around forever. This is another board book. This is from McGee. But it's there too. It's not confusing, but it's exactly the same as the modified Allen's test. The only difference is it's a 2-part test. So you're going to perform the modified Allen's and make notes about the ulnar artery. If it's working, awesome. Then it's normal. But here's the difference. You have to have the patient repeat the test again, but this time instead of releasing the pressure on the ulnar artery, you're going to release the pressure on the radial artery and see what that looks like, right? So it's a 2-part test, and that's all I need to say about it. So instead of doing this thumb would still be on, you're still clamping the ulnar artery, but you would be releasing the radial artery because that's the one we want to test, right? Everybody good with that? Pretty simple stuff. The capillary refill test, you guys know that. You basically pinch their fingernail. Do I have a picture? And it should come back within 2 seconds. I guess I don't. So you actually already know this test, but let me draw it here. So here's a fingernail. Right, there's that joint. So let's see, we'll make them pink. So you're going to pinch down. There's your finger. This is why I don't draw on the board. You're basically just going to pinch down. They cannot have nail polish up. And then with your eyeball, you're going to watch right here. It's going to turn white, right? Let's all do that to ourselves. Pinch your nail until it turns white. Now let it go, and what happens? Oh, mine turned red immediately. So that's normal. It should refill within 2 seconds. People with peripheral artery disease, when they do that, it could take 5, 6, 7, 8, 10 seconds to turn back to color again because all their pipes are clogged up with gunk. We'll talk about PAD and peripheral artery disease. But a positive is if it doesn't fill within 2 seconds, it's positive for some type of occlusion somewhere upstream. And that could be, maybe it's the hand, maybe it's the elbow, maybe it's, and you can test, you can take pulses, take the brachial artery to see if that's pulsing, try to figure out where it's coming from, right? So, yep. And it indicates, could it be peripheral artery disease as a clogging of the pipes from atherosclerosis? Maybe their heart's not working good, and they just don't have good pressure. So then you could check their lower extremities. They'd have weak pulses down there as well. Maybe it's an arterial clot. Maybe it's only on one side and their pipes are closed. But the pipes are clogged somewhere upstream is the positive for that. Okay. Some confounders. Obviously, the examination room has to be good. Not too cold. If they have peripheral edema, those are some of the I'm not really worried about those. As you can see, no stars. Hoffman's test, I threw this in last quarter. This is, I'm going to have to draw it. Let me get my drawing tools back out. So it looks like I'm going to need to do a video on that. I'm going to see if I can get my wife up here. This is my last class of the day. Okay, there's a finger. There's the fingernail. So this time, I don't know if I can draw this. You're going to take your finger, your other finger, your thumb is going to support the base of this, and you're going to flick this down, like flick, flick, flick. I'm snapping this down really hard and letting it slide off the nail. Hear that? That's my thumb, and this is my thumb right here. That's my thumb, and this is my first finger. Supporting, this finger doesn't move. You just flick that nail. What you're looking for is the thumb over here on this patient. So this is the first finger. So you're watching the thumbs hanging right here. When you flick this, the thumb should just hang here and do nothing. But if you flick this and this jerks toward the finger, that's a positive, almost like hitting the knee with the patellar reflex. You know how that jerks? That can do the same thing. That's not a good sign. That usually indicates an upper motor neuron lesion, especially a test for cervical myelopathy. Okay, I work for the spine surgeon. They always did this test, the Hoffmans Test, to screen for cervical myelopathy. What does that mean? It's usually from stenosis of the ligamentum flavum, where it squishes the back of the dorsal tracts, and proprioceptum is messed up. So we'll talk about that at a later time. Actually, I talked about that in first quarter. But did I have in first quarter? I don't think I did for spinal anatomy. Someone will definitely talk about that. Okay, so we are done. Are we done? We are done. So that's the end of Lab 1. Let's see if I can upload a little video demonstrating these. If not today, I'll get it by the, as I said, this class I'm not that worried about. If we get back before the midterms occur, I definitely will demonstrate this, and I'll demonstrate all of these tests so you can see. All right, we will see you tomorrow. We got a lot of lectures to do tomorrow. I better get busy on them. All right, see you later.